So since I previously made a video speaking about osteopathy and the claims that are made about the Spanish flu and how the treatment protocols that osteopathic practitioners actually reported with respect to the Spanish flu were not just hands-on. They used bed rest, they used baths, so sponge baths and tub baths to keep the patient clean. They also used them to make sure, or to attempt to heat the patient up to make them sweat. They used alcohol rubs to make them sweat. They used enemas to clear the bowels. They also controlled the diet. So they essentially, in varying ways, used a liquid diet until the patient's temperature was normalized for about 24 hours. Then they would reintroduce solid foods. Now, with respect to the hands-on component, the types of things that were reported varied. There was no consistency within them, but the broad themes were generally relaxation of muscles and special attention to the cervical region, the thoracic region, probably because they were considering the neurological outflow to the organs, and then special attention to the organs of excretion, right? So what they were talking about was treatment of the spleen, the stomach, the liver, and the bowel, both neurologically and mechanically. What you're going to run into with a patient who is in a hospital bed, who is having some form of sickness, they're going to be weak, they're not going to be particularly mobile. If they have a respiratory issue, they may not be able to move particularly well, and there's a lot of things that you do to them that you may have this idea that are going to be pumping types of techniques to stimulate the bowel or stimulate the liver. When they're breathing, as you push, that is going to impact respiration, right? So if I shake the patient, as long as it's gentle and non-specific, it doesn't necessarily impact breathing. But if you have something that's kind of on and off and abrupt in and around the body and in and around the abdomen of the thoracic cage, you are going to interrupt breathing. So somebody who has a respiratory condition, you have to be very, very gentle. More likely than not, the majority of the people watching this video are hands-on practitioners and not going to be in a situation where they're going to be able to treat somebody who is in respiratory distress or having a major respiratory issue that's also in a hospital. It's just not likely in most situations in the world. Where it is likely, you have to consider that what I have set up here as a table and my ability to move around freely is not going to be what's happening. What's going to be happening is you're going to have bed rails that you're not going to be able to work here, right? You're going to have wires to monitor the patient, so for oxygen saturation, for heart rate, things of that nature. So they're at least going to have a wire on their finger monitoring pulse, and I believe it's pulse oximeter, so pulse and oxygen saturation, unless, depending on where you are, it's measured a different way. But you're going to have those things being measured. You're going to have major roadblocks to what you want to do. But what I want to take the time to do is show what some of these approaches will look like. One of the major problems with these approaches is when you have somebody who really isn't able to move particularly well, is you are limited. You're not going to get the diagnostic approach that you'd like to have. You're just going to have these concepts in your head that you think are going to be helpful to the patient, such as attempting to pump the liver, attempting to pump the lymphatic system, attempting to pump this. You're not going to have a good diagnostic approach, which is why when I talk about diagnostic approach, I talk about soft tissue diagnostics, essentially as a motion test. So as you push into something, it should yield. Regardless of the type of soft tissue it is, it should yield. Anywhere that it doesn't yield, you have a motion problem that you may be able to deal with. All that being said, what you would have likely seen when these practitioners in 1918, 1919 were working in and around the organs of excretion, right? So you're going to see movement through the abdomen. It's going to be hard to see my hands, but basically what you would see is somebody come under the costal margin on either side, stomach and spleen, liver here, coming underneath, right? So they essentially put a block under the area of the liver, and you can then make the case because of location that you're also doing something to the bowel here. But you would see this, you would see them use the ribs as handles, right? And they can basically push the rib in, right? They can push the rib in, or they can keep the rib steady, and you can kind of pump here, right? So there's different ways to do this, different angulations, You can stand and do this, right? But the idea being in the area of the organ that's in your brain, the organ you're thinking of or considering, you're going to have on-off pressure to essentially create high pressure, low pressure, or a change in pressure going up, a change in pressure going down, up and down, to essentially milk, to pump, to create vacuum, whatever concept you'd like to talk about. Whether or not that's what's happening, that's the idea. So, you know, a liver pump may look something like this. It may look something like this. It may look something like this. It's going to look some way. Now remember, as I said, if somebody's actually having a respiratory issue, you can't hear it, but as I push in, I can make an audible movement of air through my patient's either nasal passage or mouth, right? So you hear, you may not hear it when I'm doing it, but basically you hear like a kind of a short blow because of the on-off pressure in the area of the diaphragm, the on-off pressure in the area of the abdomen, the on-off pressure in the area of the ribs. This can become very, very irritating to somebody with a respiratory issue, so you have to be very gentle. So if you have this idea that you want to stimulate an organ of excretion or a filter such as the liver or the spleen, that's your goal, that's your intention. You may not actually be doing that, and if somebody has a respiratory issue, you have to be very, very gentle with them. So that's where the barrier concept comes into play. Just easy on, easy off. If you have somebody who's non-ambulatory, they can't move. Anything that you can do for them has at least a chance to be helpful as far as motion of fluids that are especially passive or low pressure, so lymphatic fluid and venous blood. It doesn't mean you're doing it effectively compared to what they could do by themselves, but if they can't move, you're at least helping on some level. You can also make them more comfortable, but you know, so this would look the same regardless of side. Like I said, kind of on and off here, on and off here, you know, shake, whatever I do. The aim is to create increase and decrease in pressure. That's the concept. Whether it works to pump the liver as such remains to be answered, but that's what you would have seen in and around the liver and in and around the spleen. You can see essentially abdominal massage or working the bowel. So what you'll have is a hand kind of like this, working basically between the pelvic, more or less the ASIS, the iliac crest, and the costal margin. You can kind of work through here, right? So you'll see people basically kneading through the bowel. The idea is there's this concept that if there's anything that may be more of a solid mass, you're likely to create some mechanical pressure that might break it up, make it easier to pass. You also are essentially annoying or stimulating the bowel. So this is the concept. Whether this is true or not is hard to say, still to be determined. Some people may believe it's already been determined, but I haven't seen that information. But you see things like this, kind of these kneading on and off. Now, maybe I want to go like this, but you will get this sense from a patient and your interface between you and a patient that it's uncomfortable. So with this patient, this would not be a good speed. It would be a little bit slower, a little bit easier. The other thing to say is that on this side of the bowel, it is very rare that you'll have any solid mass. Most of the material in the ascending colon is usually still quite filled with fluid. It's quite wet, it dries out and goes over there. So if you have this concept, you have a solid mass in the bowel, it's probably on that side. But again, just kind of this kneading. That's something that you would have seen. Special attention to organs of excretion. I would do the same thing over here, but you just see my back, so it's kind of useless. You will also see this concept as far as the lymphatic system of a pedal pump or a pedal pump. Basically, they're pumping the feet to shake the whole body. So it would look more or less like this. This is what a pedal pump would look like, right? Depending on how you're set up and how the patient's set up, you know, you'll see some people who do this, right? You'll see some practitioners, I just want my patient to shake. Some people will say, no, that's wrong. You really want to kind of get the ankles going. That's why it's a pedal pump. You can put their feet on your thighs and do this. Basically, the net result is you're shaking the patient. That shaking of the patient is essentially creating, the concept is that it would create on-off pressure, that it would create increases and decreases in pressure and help move that lower pressure fluid. Whether or not that's accurate as to what's happening, this is what people will talk about. You will hear about rib raising. Now, with respect to a patient who is laid out flat in bed, in a hospital bed, you may not even be able to get to the ribs. Ideally, it would be nice to have them on their side or possibly seated. Probably won't happen if the patient's actually in the hospital. What it would look like at that point is basically you reach under the ribs and you kind of pump them. Again, this pumping concept. With somebody who has respiratory issues, you have to be very gentle here. Again, it can be quite aggravating, right? So what it might look like, I put my patient's arm over there, and I push them just so I can slide my hands in underneath, come back and just let your arm rest again, right, wherever's comfortable. Is that comfortable? Okie dokie. And this is an example of the communication that's going to happen. Your hands are squished, you can't see it, so this is kind of breaking that concept with patient positioning. Ideally, I like the patient positioned such that the anatomy that I want to work with is exposed, free to move in the planes required, and visible. This is not the case here. This is somebody who may not be able to move. I can't get them anywhere else. The rib raising, basically, some people will be quite vigorous with it, some people will not, right? Here is a reasonable place where you'd actually be able to get a bit of a diagnostic motion. So you impart motion. You basically lift. Now, some people will say you lean and lift. Some people will say you just lift with your fingers. Some people will tell you to turn your hands over and reverse bridge. A reverse bridge can be quite tender for the patient because your knuckles are poking them in the ribs. But you just push up and you'll be able to differentiate between the areas that push up well and don't. Keep in mind that the lower you are in the rib cage, the more excursion you're going to likely have. The ribs are bigger. They have a larger arc. They move farther. So you should expect less yield to your pressure as you go higher in the rib cage. But you'd have something like this. Some people would call this rib raising. With a patient, again, who is in some distress, there's a concept where you can use the arm as the lever, right? And because you're going to get the arm moving and pulling on muscles that will attach to the ribs in various locations, you could be lifting ribs this way. If you have a patient who has a respiratory issue, that's probably going to be a lot for them. It's probably going to be too vigorous, not gentle enough. You will then also see a concept of lymphatic pumping through rib pumping, or kind of make-break pressure on the ribs, on and off. And when you do this, you definitely have to be careful, because once you're actually moving the ribs themselves with force, kind of decreasing the size of the cage, you're definitely going to be in a situation where you can impact somebody's airway, or you can impact air coming in and out, and you'll hear it if you're doing it at a certain rhythm. You'll again hear that kind of short burst of breath, as long as the patient can stay relaxed enough. That looks like this. Now, depending on who you're working on, it can be in the upper ribs. You want to be careful with where your hands are, because for some people it's just generally uncomfortable. Man, woman, any other description. Hands on chest, hands on the anterior portion of the thorax can be uncomfortable for a lot of reasons, and it's not yours to necessarily figure out. But if you recognize it's uncomfortable, I'm going to show you a way to change this. Here, some people will sit, I would say, to stand, because you can just lean on. And as you do this, you may notice, if you're paying attention, one side does not yield as well as the other. So the simple sinking in through the tissue can tell you that. You can have the patient take a deep breath, so take a deep breath and let it out, and you just look at your hands. You're not going to feel the difference here necessarily. You're going to see a difference. One side will look like it moves a little bit more freely, and it can be for a variety of reasons. Some people will call this lymphatic pumping, so on, off, on, off. Some people will call that lymphatic pumping. Some people will talk about that being a rib treatment. They look exactly the same. The way that you apply them is by paying attention to the patient and seeing what's comfortable, right? So a way to do this is just let the patient breathe as they normally would. You watch their abdomen, and as the abdomen drops, then what ends up happening is you can sink a little farther down. All right, so this is very, very easy, very gentle. You don't overbear on this if you do it in this way. And as they're breathing in, you can come off, right? Now that tends to, because you're rapidly changing the size of the thoracic cage, that tends to really heavily force air through the airway. And if there's any built up obstruction in the airway, you'll often hear it. It'll sound like somebody with a bunch of mucus. Maybe they have a bunch of mucus, maybe they don't. I don't know for sure because I don't have a way to diagnose inside. But I can just let them breathe normally, and then as I'm dropping in, and then I can drop off fast. Don't make it gigantic because that's a little scary and it'll mess with your head. But you can do that. Or you can, if they're capable, take a deep breath. You hold on to the ribs, don't let them up much, they're going to come up, and then let it out. Right? Take a deep breath. And it's the same thing, but you can actively engage them. So patient active versus patient passive. Or you can just do a pump. Looks like that. And you're going to have to break the rhythm every once in a while because the patient is going to be uncomfortable because they don't know how to breathe at that point. Because you're literally taking over their breath or really interrupting the rhythm of it, moving air through the airway quite fast. One of the things you can do is cross your arms. Okay? Now, because their arms are in contact with their thorax, this is obviously uneven, one arm's over the other. It doesn't matter in which way, but I can still do my pumping. Now my hands are not on my patient's thorax, so it may be more comfortable, it may be more uncomfortable. You're going to have to figure that out with the patient. What I wanted you to see here is what these treatments look like. Pumping an organ, working on the bowel, a lymphatic pump, a pedal pump. The idea is that you're trying to shake the patient, you're trying to increase pressure, decrease pressure, change the rate at which that's happening for an immobile patient. Let's just say you're in a hospital room, you're not going to be able to stand at the head of the table or at the head of the bed because it's against the wall and everything's plugged into the wall, so you're not going to be able to get there. What's a way that you can pump those ribs, right, to create that vacuum pressure? You can come into the costal margin. It's not the same thing because it doesn't really change the size of the cage. You're not going to get that fast breath out of this, but you can do it here. Cross your arms again. If you have access, you can come in here and you can pump like that, right? Because if I'm down here, my hands go on the thorax, I'm definitely going to make people uncomfortable, regardless of description. I'm going to make people uncomfortable. I'm down here and on the ribs, but I can do varying holds here, and I can pump that way, right? So that's another option. What you're looking at is that on and off, on and off. That's the concept to change pressure. Whether or not mechanistically it's doing what we claim it does is worth questioning, but that's what it would have looked like. Those are some of the ways it would have looked as far as treating during the time of the Spanish flu. Another thing, when you can't do the pedal pump, right, as long as you can shake somebody, right, just kind of shake them, that is very similar, the shake, right? So I can just get a rhythm going, shake my patient to create that movement that may end up pumping some low pressure fluid. It's the same concept as being down there. So when you are not able to access a patient in a specific way, you can't move them, you can't see what you're wanting to see. One of the diagnostics that you have is pushing into soft tissues where it doesn't yield. That's a motion restriction. You can deal with that. The concept of pumping doesn't have much of a diagnostic. Pumping doesn't have a diagnostic. You have a desire to move passive fluid for some reason. You go ahead and you do it. Right? There is no real diagnostic. There's no real barrier with that aside from making the patient heavily uncomfortable. You push in and they jump, they wince, they pull back. When somebody's actually sick, you have to be extremely gentle because you may do something that creates a pain response, that creates some form of inflammatory response that you don't see coming, so you have to be very gentle. And again, I'm doing this to display what it may have looked like so that you have some concept of it, a way to see it done in varying angles, but most of us who are watching this would not have access to a patient in a hospital in an infectious situation for good reason. A practitioner who is around a patient who's infected with a transmittable virus, or essentially, something that can be passed on quite easily, becomes a vector for infection. A vector being kind of a distance and a direction. So I move from point A to point B, left to right. Therefore, anything that was between me left to right, I have put virus on. Practitioners who are seeing lots of people in a given day without appropriate infection control are a very large problem. I am not here to suggest that I believe that these methods would reduce infection rates, they would cure infections. What I would say is that osteopathic care provided to patients during the Spanish flu epidemic of 1918 to 1919 was quite supportive of normal bodily function, so excretory function, good hygiene, good sanitation, good segregation, because the osteopathic practitioners at the time were very good at keeping people segregated, lots of sterilization, lots of washing of clothes. This is what's reported. The hands-on component was part of it, but it was not the most salient feature. The most salient feature was essentially bed rest, controlling the diet, controlling or supporting normal functions of excretion, keeping the patient clean, keeping the patient separated. The OMT did happen. It might have looked something like some of what I showed you insofar as working on these organs, pumping low pressure fluid, but this is not going to cure an infection. It is supportive care. It may make the patient more comfortable. It may decrease the length of time that it takes for the virus to work its way through. It's at least possible, because when you look at osteopathic care, and a place where it's succeeding in the hospital setting is decreasing length of stay. It does not mean it cures an infection. It means it seems to be supportive. So if you are in a situation and you're theorizing about what this might have looked like, this is what it might have looked like, I would suggest to anybody out there watching this, don't go try to do this if you don't have hospital privileges, if you don't know what infection control looks like. I'm just doing this to share with you what it might have looked like at the time of the 1918-1919 Spanish flu. And I'm also trying to reinforce that this was not the central part of treatment that osteopathic practitioners provided or osteopathic physicians provided. The central feature was good hygiene, bed rest, controlling the diet, enemas, and keeping people segregated. That was the central piece. Again, I will repeat, hands-on treatment did happen. It was not central.